Hi, good morning. I'm Dr. Lilian Abbo. It's my pleasure to be here today. I really want to thank the organizers of the Pan American Trauma Society for the kind invitation, and I hope you enjoy this session. I'm going to be speaking about COVID-19. What have we learned so far in 2020, and what can we expect for 2021? As you all know, our world has changed. This pandemic has truly challenged our lives, our health system's operational, fiscal viability, and human capital. And it also has taught us a lot about this disease. We have been seeing it range from asymptomatic people to people who die, and we still don't know enough why. Our knowledge and guidelines continue to evolve. And like many of you, this pandemic has infected and affected my family, personal friends, and colleagues. But I want to leave a message that there's still hope. As of October 10th, we know that around the world, we have over 37 million cases of COVID-19, causing over 1 million deaths. Unfortunately, the United States of America is leading the number of infections and the number of deaths around the world, just being followed by Brazil, India, and Mexico. Tony Fauci gave ground rounds at Harvard University on September 10th and was asked what are the lessons that he has so far learned from this pandemic. And according to Dr. Fauci, I'm going to share the top lessons. Number one, do not ever underestimate the impact of a pandemic or ever try to sugarcoat it. We've learned this with HIV, where initially they saw one gay man having, this rare disease, and then went to 26, and then we have over 75 million people infected with HIV or AIDS around the world. Well, the same thing I think has happened with COVID. When this first started, many places thought, oh, we don't have direct flights from China. Oh, we're not Italy. Our health systems are better. We're different. We have all been affected by this everywhere around the world, regardless of your economic status, your race, or your age. Number two, stick to the science. I think it's very easy to feel that you have to throw everything at the patient because this doesn't work, let's try something else. But there's really something to be said about the role of ethical, well-sound, well-done controlled clinical trials. And I think we've all learned how things have evolved very rapidly in this pandemic, where we all throw one drug and then everybody's finding another paper that shows that that drug didn't work. So really sticking to the science, I think it's extremely important so we can continue to find better treatments, cures, and preventive methods. Three, we have to be very nimble and flexible, adapting to new information. We really need to be humble. We need to admit that we don't know everything from the beginning of the pandemic and throughout the pandemic. And we need to be flexible to change guidelines, protocols, and treatments as we learn more and as data evolves. And number four, address existing healthcare disparities. And we've seen this in the United States, where communities that are Black and Hispanic have been more affected than others. And we really need to understand the social determinants of health and close these gaps around the world so everyone can have access to preventive care, to primary care, and be able to prevent these serious infections and comorbidities. Some of the other lessons that I have learned, besides Dr. Fauci, I'm going to share with you in the next few minutes. Number one, we've learned that the risk of hospitalization is going to depend on the human behaviors. If you are attending crowded situations, close physical contact, in closed space, and the duration of exposure. More and more data has shown that depending on the risk of comorbidities, the risk also of hospitalization or death increases. We know that asthma, hypertension, and obesity progressively increase the risk of severity of disease, followed by diabetes, chronic kidney disease, severe obesity, and if you have two or more of these conditions, you have 4.5 times more risk of developing severe disease, and if you have 3 or more conditions, the risk elevates 5 times more. How can we prevent COVID infections? Wearing a mask all the time, maintaining the physical distance with these 6 feet or 2 meters apart, the hand hygiene, and the cleaning of disinfection. But we really need to understand that even though the risk increases with age, everyone is at risk, and everyone from children to elderly need to protect themselves and the community. What are some of the keys to success that we have learned? We have to plan, we have to prepare, and we have to adapt. And at the health system level, we need to have operations and clinical. There are 3 P's in operations: people, products, and places. And on the clinical side is how to triage, how to test quickly, how to trace, and how to treat. I'm just going to share an overview of how we prepare at Jackson Health System and at the University of Miami. We have an administrative and a clinical core leadership team, and the response has been across the board with leaders, with the communications department, making sure that at all times we share what we know and what we don't know. You need transparent and frequent communications at all levels, at a hospital level, at the community level, and at a country level. Infection control measures, how to restrict visits, how to isolate patients, how to train people on wearing, donning and doffing the PPE, information and technology, how to use the computer systems to create dashboards, to expand telemedicine, to communicate with people, and to share protocols in our electronic medical records. Patient care and developing protocols and trials has been extremely important, deciding which clinical trials we have the capacity to do and how to share that information, and developing protocols in operating rooms, in intensive care units, emergency medicine, trauma, transplant, and all the areas that we touch in the hospital. Laboratory testing has been key, making sure that we can provide rapid results that are reliable and that are accurate. Pharmacy, making sure that at all times we have medications and we can project when are we going to have a shortage, so we don't reach the time where you are like, oh my goodness, I don't have anything to treat my patients. From critical care to operating rooms to COVID treatment medications. Keeping up to date to the literature and assigning somebody who's responsible for like reviewing the literature, as none of us has the time to read everything every minute. The supply chain and procurement to make sure that you have what you need, from ventilators, masks, PPE. Working with employee health to make sure that we have enough human resources, enough employees, but also that we provide the emotional support so people don't continue to burn out. And then community partnerships and making sure that we work together across hospitals, across countries, and making sure that we are able to provide a response to our community. And last but not least, very important, your engineering controls and making sure that you have from environmental workers, infection prevention, biomedical engineers, that you can convert negative pressure rooms where you need it, that you clean and disinfect appropriately. All of that has to be part of our robust response to a pandemic. And we have been also working with our county officials and our governors as a public health system. So that's also important. One of the things that people want to know is how is this transmitted, droplet versus aerosols? As you all know, there has been a lot of controversy. I think initially, we've all known since the beginning that most transmissions have been through close contact, less than 6 feet. What the CDC has updated is that so far, there is no evidence that this is transmitted as other diseases like tuberculosis or varicella. In high aerosols, we do see aerosol transmission, but the primary route is droplet and contact. The difference between droplets is that there are more than 5 micromicrons, and they really fall into earth quickly. Aerosols are less than 5 micromicrons, and they usually suspend in the air and they recirculate in their air handling units, and they can travel on air currents for hours. And we also know there is eye transmission through the ocular mucosa. That's why the eye protection is so important. So I think what we have learned is there are different routes, and depending on the environment you are, you can acquire COVID through droplets or aerosols and contact, regardless of the route. And then we also know that 40 to 45% of the people are asymptomatic and they can still transmit and spread the infection. We know that in the hospitals, these are the aerosol generating procedures. I think many of you are already familiar with that, and we need to wear a higher level of PPE protection for these procedures. But if you're in the community, the airborne transmission has been shown in indoor activities without a mask and without physical distance. So for example, if you're traveling on an airplane and nobody's wearing the mask, that's a very high risk. If you're going to work out in a gym, or if you're going into an indoor dining where you have to take out your mask to work out, or you have to take out your mask to eat, and you're in close proximity, that is probably the highest risk. So being in enclosed spaces, prolonged exposure more than 30 minutes to the respiratory particles, or if you're in a car with a lot of people or just one person not wearing the mask and in very close contact, and inadequate ventilation or air handling because the air recirculates. So those are the 3 circumstances where airborne transmission, in addition to a droplet, is a high risk. We've also learned throughout this pandemic that there is variation in the diagnostic test results relative to symptoms. We know that in the few days, maybe 5 to 6 days before the symptom onset, you already have viral replication. And there, it probability increases during week 1 where your symptoms start, where the PCR then is going to start declining. And then we're going to start seeing after the first week of symptoms how IgM and IgG start to appear. The CDC has more and more data showing that we use the cycle time values on the PCR, and we know that with higher cycle times values, they use the cutoff of 33, but it varies by instrument. But if you have cycle times values closer to 40, that means that the virus is probably non-competent and they have not been able to retrieve that virus in viral culture. Lower cycle time values, lower than 30, are actually highly infectious and highly transmittable. We also know, as I mentioned before, that pre-symptomatic, symptomatic, and asymptomatic actually share the same viral loads and are actually transmitting infection. And that is extremely important because even a few days before you develop symptoms, you're already able to infect others. And that's what makes this virus so hard to control. Duration of isolation, we have learned a lot. In September 10th, the CDC updated the guidelines. We know that if most people, non-immunocompromised, non-critically ill, are going to be shedding virus and infections for about 10 days following the symptom onset. So that's why we say that after 10 days of onset of symptoms and 24 hours without a fever is probably safe to stop isolation measures. However, the replication of competent virus in critically ill or immunocompromised has been found between 10 and 15 days, and we use up to 20 days of isolation for more critically ill patients because there is a high risk that they're still shedding and transmitting virus. We know that household contacts are at risk. We do know that not 100% of the household contacts sometimes get infected. We have seen families where everyone gets infected, and we've seen others where only one person in the household gets infected. What we know more is that apparently if you are exposed after 6 days of the onset of illness, that's actually when your exposure increases. And we know that even though we're not infectious between 10 and 20 days after the onset of symptoms, or if you're asymptomatic, the PCR can remain positive up to 12 weeks. So you can have detectable RNA up to 90 days after the infection. We still don't know if you're going to have short and long-term immunity, and that is being still studied. Can we get reinfected? Still, there's some unicorns, some isolated reports of reinfection. So far, the CDC says that in the first 90 days, in the first 3 months, we have not seen reinfections. However, we all need to behave, even if you recovered from COVID, as you've never had it, and wear your mask, maintain your physical distance. And if anyone develops new respiratory symptoms, they need to be evaluated and retested. I think something very important that I want to share is the stages of COVID illness. We have early infection with a viral response, and then we have a host inflammatory response where we are seeing this hyperinflammation, what everyone has been calling the cytokine storm. But we recently reported on October 9th in MMWR a case series of multisystem inflammatory syndrome in adults, similar to what we're seeing in children. And what is different about this is these are usually adults that have recovered from COVID, they have very mild or asymptomatic, and a few weeks later, they're presenting with this multisystem inflammatory syndrome with cardiac, dermatologic, GI, or renal involvement with very high inflammatory markers. And we're really trying to understand why some patients are more susceptible to this, and you really need to have it high in your index of suspicion and pretest probability. Check antibodies. PCR is usually negative and antibodies are positive. And these people can tell you somebody that they know had COVID or they were in close contact, they knew they had mild or asymptomatic COVID, and a couple of weeks later, they're coming in with severe inflammatory disease. I'm not going to touch upon diagnostic and therapeutic stewardship. I think this is going to be touched upon my colleagues. But I do want to mention what are the long-term consequences. And there's still no clear definition of what is the post-acute COVID-19. But in a recent survey from the CDC, 35% of the people still with mild disease, ambulatory, after 2 weeks, were having symptoms and not able to return back to their baseline. And this was in elderly and young people older than 18. This is really important. We all need to start building outpatient clinics and monitor the long-term sequela. We need a multidisciplinary approach. We need a thoughtfully well-integrated research agenda, break the silos, and allow the comprehensive study of what are the long-term consequences from fatigue to dyspnea to anosmia, brain fog, alopecia, new onset diabetes, cardiovascular and vascular thrombosis, and most important, the psychological impact that this has in our patients and our healthcare workers, the isolation, hopelessness, and loneliness. So what can we expect for 2021? In my opinion, it will all depend on how we behave. We need to continue using masks and physical distancing. We really need better knowledge on how this disease gets transmitted, how do we get reinfected, understand the short and long-term immunity. We need accurate, affordable, low-cost, and easy-to-use diagnostic tests. We need evidence-based decisions for treatment and prophylaxis, who to treat, how to treat, from anticoagulation to antivirals. How is convalescent plasma helping? We need randomized controlled trial results and the mesenchymal stem cells. We need new repurposed drugs or figure out how to treat severe ARDS, better management of steroids, proning, ventilators, and ECMO. And we really need the data on the monoclonal antibodies to understand for prophylaxis and treatment, what's the role and who will be a candidate, as we know that not everyone will be a candidate for a vaccine. And we definitely need more than one vaccine, as we need to vaccinate 7.2 million people around the world. So definitely we will see more than one candidate in 2021. A pessimist sees the difficulty in every opportunity, but as an optimist, I always want to see the opportunities in every difficulty. So I want to leave you with the message that we have made great progress and there is hope. The multidisciplinary collaborations that we've seen around the world have been impressive, and we have shared rapid knowledge of information, and we need to continue to do this beyond the pandemic. This is a very serious disease. Please stay humble. Have respect for this virus. Do not let your guard down. This is not over. But very importantly, as physicians, we always take care of others. We need to take care of ourselves. This is a marathon, and we all need to run together and get through the finish line. We have lost too many lives, and too many healthcare workers have died during this pandemic. I want each and every one of you to come safely to the finish line with me. Thank you very much, and I'll be happy to answer any questions.